to understand, make idea about the disposition of peritoneum. Where from the peritoneum is reflecting and what does it making within the abdomen. Peritoneum is the greatest serous sac in our body, and it has two layers. The parietal layer that lines the walls of the abdomen, and the visceral layer that falls on the surface of the viscera. The parietal layer is formed by the somatofluoric layer of the lateral plate mesoderm, and the visceral layer is formed by the splangnofluoric layer of lateral plate mesoderm. All right. Peritoneum has a great healing power. Peritoneum, it may get infected, but it has a great healing power. Whenever in abdominal operation, suppose we cut the root of the appendix, infected appendix, what we do? We tie the vessel, tie the root of the appendix, then we cut it, and the cut surface we ligate, and the cut surface is the peritoneal pad is always placed over this cut surface. Similarly, if we do an intestinal anastomosis or repair of the gastric ulcer or the perforated duodenal ulcer or the gut perforation, what we always do after the repair, we put a piece of peritoneal pad over the repaired area. Why? Because it helps the healing of the layer. Peritoneum has a great absorptive power. The large surface area, which is lined by the mesothelial cells, having microvilli, it has a great absorptive power. So when there is acute renal failure and there is no arrangement for hemodialysis, you can make a hole into the peritoneal cavity and put the peritoneal dialysis fluid within the abdomen. Alright, there will be exchanges of proteins and urea, as well as there will be addition of electrolytes that are important to the body. And this peritoneal dialysis was for a long helping the human being in cases of acute renal failure. There is another importance of peritoneum, that is when there is obstructed hydrocephalus, the ventricles are dilated, there is a great amount of CSF within this with increased intercerebral pressure. Then what we do? We make a bar hole just at the junction of the behind the coronal suture. Nibble out the inner layer of the bone, parietal table, and then put a catheter, small bone catheter into the lateral ventricle, and from there the rest of the tube passes below the scalp, then over the neck, below the chest wall, below the neck wall, below the chest wall, and then we put this lower end of the tube either into the peritoneal cavity, or a small gastrostomy is done and the lower end of the tube is put into the stomach. Right? Both methods are available. So when we put the tube into the peritoneal cavity, it is called ventriculoperitoneal shunt. It is called ventriculoperitoneal shunt. Right? Another thing is important. That is, in case of the male, the peritoneal cavity is a sealed cavity. But in case of female, the posterior layer of broad ligament is pierced by the uterine tube. Posterior layer of the broad ligament is pierced by the uterine tube, and the oocytes move within the peritoneal cavity, and the peritoneal cavity after ovulation, and the uterine tube collects the oocytes from the freely moving ovum within the peritoneal tube. So within the peritoneal serous sac. So the peritoneum is pierced, that is, it has a hole in the posterior layer, so it is not intact. So there is a chance of infection. In case of the female, they are at great risk, but the male, as their peritoneal sac is sealed one, so there is no higher risk for infection, right? Now, again I am repeating that it is very tough to understand how the continuity of the peritoneum is maintained. We study peritoneum by dividing it into greater sac and the lesser sac. Greater sac means the peritoneum, which is coming from the abdominal parietal, all right, lining the parietal abdominal wall, falling on different structures, and then again coming back to the parietal part of the abdomen, that is making the greater sac, and a part of it, that is the diverticula of the greater sac, that is behind and below the stomach, that forms the lesser sac. All right. Now today I will discuss only the vertical. We study the peritoneum vertically, that is its vertical disposition, and horizontally, that is its horizontal disposition, right? Now you see, from the anterior abdominal wall, there is falling of the parietal peritoneum over the liver, in between the anatomical right and left lobe of liver. This sickle-shaped fold is known as the falciform ligament, right? Above there is the fold that comes from the diaphragm, under surface of diaphragm. The right one is the right triangular ligament, that is the superior layer of coronary ligament, and the lower one is the right triangular ligament. And on the left part, that is the left coronary ligament and the left triangular ligament. There is a free posterior margin of the sickle-shaped falciform ligament. Through this posterior margin, there runs the ligamentum teres hepatis, right, together with some tributaries. Below the umbilicus, you can see that there are medial umbilical ligament, medial umbilical ligament, and the lateral umbilical ligament, and there are 5 foci in between this ligament, and there is a triangle that is formed between the inguinal ligament below, medially the lateral border of the rectus sheath, and laterally the lateral umbilical fold. This part is called, as you know, this Hazelback triangle, through which passes the inferior epigastric artery, Any hernia medial to this triangle is called direct hernia, coming directly from the posterior wall of the inguinal canal. And lateral to it is one is the indirect hernia passing through the deep ring. All right. Have you seen this portion of the peritoneum, peritoneal folds? Where to be seen? Where to be seen for these umbilical folds and foci? What to be looked for? Where to look for? You have seen abdominal dissections? The anterior wall, chest wall together with the anterior wall of the abdomen. It is dissected out and it is reflected like this. You haven't seen? You haven't seen. So there you can find all these medial umbilical ligament, medial and lateral umbilical ligament and the fossa, peritoneal fossa. All right. Now the disposition of peritoneum in a summary is understood by this diagram, where we see the 3½ diagram of the gut, and in between there is the image of the transverse mesocolon. Abdomen, if you open the abdomen, you will not be able to see the gut or the stomach. You will not be able to see because there is an apron coming from the transverse mesocolon, which is known as the greater omentum. That's why you cannot see the gut or the stomach. And this image is called 3½ photograph of the abdomen. Do you understand? Here is the ascending colon, this is the descending colon, this is the sigmoid colon, and above that is the transverse colon. And the apron that is coming down is the greater omentum. Understood? Now to make your idea clear about what is the greater sac, you see from the parietal abdomen, the layer is lining the walls of the abdomen, and on the posterior aspect it is making a gutter. On the right side, the right paracolic gutter, and on the left side is the left paracolic gutter. The right paracolic gutter holds the ascending colon, and the left paracolic gutter holds the descending colon. And the two layers of this fold comes in the midline and go to invade the gut, which is known as the mesentery. Two layers of these two paracolic gutter, peritoneum of these two layers goes to invade the gut and supplies its nutrition via the blood vessels and nerves. And you see in the cross section, that is the position of the greater omentum. That is the position of the greater omentum. Right? Most of the organs of the abdomen is lined by peritoneum of the greater sac. All right? Except the posterior inferior surface of the stomach, posterior surface of the duodenum, anterior surface of the neck, body and tail of pancreas, part of right kidney and right suprarenal gland. These are supplied by the peritoneum of the lesser sac. Right? Rest of the surfaces are lined by peritoneum of the greater sac. There are folds between the greater and lesser sac. This fold of peritoneum holds organs to different structure. Omentum means the connection of the stomach with other organs. This is called omentum. And it is called mesocolon when the peritoneal fold holds the mesocolon with other structure. This is called mesocolon. And the mesentery when the folds of peritoneum encircles the gut. Right? There are some other folds which carry blood vessels, like the paraduodenal fold that carries the inferior mesenteric node, inferior mesenteric vein. The left gastropancreatic fold that carries the left gastric artery, and the right gastropancreatic fold that carries the hepatic artery. So there are some peritoneal folds that transverse blood vessels. The left gastropancreatic fold conveys the left gastric artery. Right gastropancreatic fold holds the right hepatic artery, and the paraduodenal fold conveys the inferior mesenteric vein, not artery. All right. So we have discussed the what is omentum, what is mesocolon, what is the ligament. Peritoneal folds from the stomach to the undersurface of diaphragm, to the spleen, to the kidney. These are termed gastrophrenic ligament, gastrosplenic ligament, gastrosplenic ligament. All right. These are lionolelal ligament. These are folds of peritoneum that are connecting the stomach with the structures around. Right. Now,
60, 70, 80, 90, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 40, 49, 50, 51, 51, 52, 53, 54, 55, 55, 56, 57, 58, 59, 60, 61, 62, 63, 63, 64, 65, 66, 67, 68, 69.
You see, the peritoneum from the liver is projected towards the kidney, right kidney and the right suprarenal gland. And the right suprarenal gland. This is known as this is known as the hepatorenal pouch of Morrison. This is known as the hepatorenal pouch of Morrison. And lower down, there is the formation of the peritoneum lining that is the formation of the right paracolic gutter. From there, the peritoneum goes to the pelvic cavity, crossing the pelvic brim and lines the anterior and lateral surface of the upper third of the rectum and the middle and only the anterior surface of the middle third of the rectum. Right? Anterior and lateral surface of the upper third of rectum and anterior surface of middle third of rectum. And from there, it goes to the posterior surface of the base of the bladder, forming a rectovesical pouch. In case of female, the peritoneum falls on the posterior surface of the cervix, forming rectouterine pouch. Right? Here it is the rectovesical pouch. And in case of the female, when the peritoneum falls on the posterior aspect of the vagina, it forms the rectouterine pouch of Douglas. After that, falling over in case of male, falling over the base of the urinary bladder, covering the part of seminal vesicles and the vas deferens, cover the superior surface of the bladder and comes to the parietal abdomen. Right? Got the continuity? In vertical disposition, I will discuss the horizontal disposition of the peritoneum in a later date. Right? Thank you all.